We'll proceed to the next section on comprehensive overview on glaucoma management. I invite Dr. Abhilash, Dr. Rizana, and Dr. Priyanka to take the stage. Without ado, we'll move to the first talk by Dr. Rizana on counseling a newly diagnosed glaucoma patient. Over to you, Rizana.
Good morning, everyone. Today, my topic of presentation is counseling a newly diagnosed glaucoma patient. So, as we all know, glaucoma is a sneak thief of vision. Before understanding the importance of counseling, it is very important to know the barriers in successful treatment of a case of glaucoma. There are disease-centric issues as well as patient-centric issues. Patient-centric issues include inadequate awareness among the patients, non-adherence to treatment, non-affordability of treatment. All these issues can be sorted out with a proper counseling. So the purpose of counseling is to improve the success rate of treatment by making them aware about the disease, to help them accept the prognosis, to improve compliance to medical management, and to find out exactly what the patients need, and to refer them to low vision services and help them to improve their quality of life. When to counsel is the next question. Actually, the first session can be planned immediately after the diagnosis is confirmed. 10 to 15 minutes of dedicated counseling can have a great impact on the long-term outcome of the disease. It has to be in mother tongue, and further sessions can be planned as often as needed, and the frequency of that can vary from case to case. The examining clinician is the ideal person to counsel, but owing to the busy nature of practice of Indian clinicians, this is not possible many times. So the glaucoma care team can train a person to take up this role. It can be a nurse, a social worker, an optometrist, a postgraduate, or a fellow. Anyone can take this role, but the person has to be approachable and skilled at talking to the patients and bystanders, and he or she should have a reasonable understanding of the disease and its treatment. And the clinician should clearly convey the details regarding the patient to the counselor, because the ultimate responsibility is with the clinician. And it is very important to include family members as well, because defective vision is not without any evident findings like a white pupil, as you see in a case of cataract. And often the adverse effects of anti-glaucoma medications like red eyes is usually many times misinterpreted as alcohol abuse. All these problems are there. So it is very important to include family members when you're counseling them. And constant visits and expensive treatment are without any evident improvement in vision. So it might be difficult for the patient to explain and convince the family members. So when explaining about the disease, do not overload with facts, and ask them how much they know about the disease, and explain regarding genetic predisposition also, so that they can encourage their relatives to get screened. And it might be needed to explain repeatedly, especially when you're dealing with a patient who is denying. Every time you have to present in different methods to avoid monotony, and when dealing with them, avoid harsh languages and give them time and space to go through various stages of grief. And it's very important to encourage them to be compliant about their medical management. The counselor has to ask about the frequency of medications, to demonstrate how they instill it, to inquire about any barriers if present in proper installation of medications. All these are very important. And we can encourage them to keep reminders so that they don't miss medications at the correct time. And explain about the possible adverse effects of the medications which are prescribed to them. And to improve the quality of life, it is important to guide them to low vision services also, to get equipments and training to make best use of their available vision. And it's important to encourage them to join support groups for people with glaucoma. And peer mentoring is a technique in which a patient is connected to another one with a similar condition, so that they'll get guidance towards developing self-help and personal grooming skills. And this is a methodology which you can practice while counseling. Ask the patient what they know about glaucoma. So then you will have to explain about the multifactorial nature of the disease, and tell them that IOP is the only modifiable risk factor. This helps them to avoid unnecessary anxiety and encourage them to take medication seriously. And inquire about whether they know about the symptomatology with which patients present. This will help them to educate others. Ask about the aim of treatment of glaucoma. Just tell that this is not for improving vision, but with regular follow-up, they can keep the disease under control. And tell them that these medications and follow-ups are to be continued lifelong. Ask about family history so that they can encourage their relatives to get screened, and ask about whether they are seeing some patterns or objects which others are not seeing, and explain to them about this phenomenon called Charles Bonnet phenomenon, and tell them that this is nothing to worry about. If you want, I can explain this to your family members so that they won't misinterpret you as malingering, or as blaming to have mental illness, etc. So, in nutshell, patience and consistency is the most important thing in a successful treatment of glaucoma, and this can be achieved with the proper counseling. Thank you so much.
Thank you, Rizana. For the next talk, I invite Dr. Abhilash Nair to talk on target IOP, initiating medical management for glaucoma.
At the outset, I'd like to thank Dr. Manoj for this opportunity. And yeah, my talk is Target IOP and Initiating the Medical Management of Glaucoma. So the aim of our treatment is to maintain the quality of life of the patient. And this is mainly by maintaining the visual function at a sustainable cost. So when we think about starting a medication for the newly diagnosed glaucoma patient, there are a lot of factors which we as clinicians do not really think about. And I think Dr. Rizana has touched upon a lot of those factors which are very, very important in management of glaucoma. We always talk about drugs and surgeries and everything, but from the patient side, there are a lot of psychological and social factors which we also need to be aware of, even if maybe we are not having time to go into. But the aim is to avoid blindness for the patient, and that depends upon a lot of factors which we have to look upon when we start our treatment. So a lot of the quality of life of the patient depends upon the personal preferences of the patient, and anybody who has been diagnosed with a disease would like to always maintain their personal lifestyle. So that will depend upon what sort of hobbies they have, what are their preferences, what sort of activities they have, what occupation do they have, how much of social support they are getting from the others around them, and of course, general health of the patient, what all medicines they are having, what are the side effects of the medicines, and what are the effects our medicines are going to have on those diseases. So the cost of glaucoma is not just the cost of the medicines that the patient is buying. It also includes the cost of the investigations the patient has to do, the person who has to accompany the patient to the clinic, the social burden of the disease, and the psychological trauma. Always establish the severity of the disease, and that is, you have to check the baseline IOP, which may not be easy when you are having a patient who is already on drugs. You may not be able to stop all the medications to check the baseline IOP. You can always take a history, and always the baseline IOP includes at least 3 measurements taken at different times of the day. Field changes are important to note how much of the visual function patient is having at that time, and always assess the risk of progression. The risk of progression includes the age of the patient. The patient is having at a younger age when diagnosis occurs. That means the risk of progression is more through the lifetime of the individual. The intraocular pressure, any other risk factors the patient may be having, genetic predisposition to glaucoma, type of glaucoma, etc. Now, all this being said and done, the patient is always going to be worried about the functional damage the patient is going to face during his lifetime, like maybe an inability to drive. Patient may suffer falls due to his decrease in field of vision. The reading may go down, and finally, a lack of awareness or orientation around his surroundings. Now, staging of glaucoma can be done by many methods. The ONH examination is easiest to be done, but it is more or less subjective. It depends upon the pupillary size, what sort of examination you are doing, how experienced you are at the clinic. And it should always correlate with the objective methods that we are doing for the patient, the test that we are doing, OCT or fields or whatever. DDLS is good, given by Spaeth et al. I'm not going to the details due to lack of time. It's very good, but it's cumbersome to follow for each patient. Perimetric staging is easier if it is well done, and it has to be repeated and make sure that there is no learning curve. And a mean deviation of less than 6 is an early perimetric glaucoma. Moderate is 6 to 12, and severe is more than 12 decibels. Of course, scotomas within 5 degrees of fixation means it is an end-stage glaucoma. And as I mentioned earlier, the patient is probably more worried about the lack of contrast, the restriction in his daily lifestyle and inability to do his preferred activities. There are many classifications regarding staging of glaucoma. And regarding coming to glaucoma treatment, so this graph is taken from European Glaucoma Society, and it shows the visual degradation during the lifetime of an individual. So A is the normal person. Everyone has a decrease in the visual function, and the other alphabets B to E are different patients. So we can see that some patients like E are very fast progressors. So those patients require very aggressive treatment. B and C patients have similar amount of visual disability, and the rate of progress also similar. But the difference is that C patient has been diagnosed with the glaucoma very early in life. So the risk of progression is much more in patient C compared to patient B. So patient C has to be taken care of much better than patient B. And D is progressing at a very slow rate. So in patient B and D, we probably need not even treat them, just observe them. Coming to the topic proper, target IOP. Target IOP, there are lots of definitions. I'm not going to read all of them, but it is the upper limit of IOP that slows the rate of glaucoma progression sufficiently so as to maintain the patient's quality of life. Now, there are important considerations. The target IOP is a dynamic figure. It's not set in stone. It has to change as you treat the patient. So if you feel that the IOP is not enough, the patient is progressing, then you may have to lower the target. If you feel that the patient is having complications and the glaucoma is not progressing as much, then probably you can maybe even raise the target. It's always a compromise between the visual loss and the cost of therapy. Now, everything I've been mentioning has been taking the glaucoma patient as a whole. Target IOP is separate for each eye. It's not the patient's target IOP, it's the eye's target IOP. So again, from European Glaucoma Society, these are the considerations that you must take into account when you set a target IOP. Now, target IOP can be either a percentage reduction, could be a threshold IOP, or it could be calculated using formulas. There are numerous formulas available. There are numerous nomograms available. We usually don't follow them. I think Jampel's formula is the most commonly used formula. All the big RCT studies used percentage reduction to, as a guideline to note how much of the glaucoma is progressing. And according to those, the ocular hypertensives were supposed to have a reduction of at least 20%, mild glaucomas 25%, normal tension glaucomas 30%, moderate 30 to 35%, and advanced disease 40%. These are AAO guidelines. If you want a threshold IOP, again, that is also available from these studies. And if it is a suspect you may have to reduce it less than 24. Early glaucoma 20 or less, moderate 17, and advanced 14 from the AAG study. So this is a graph that shows the initial untreated IOP with the percentage reduction that you want. So the person is having a 25 initial IOP and you want a 40% reduction. That means you can see that around you need 15 millimeters of mercury as the target IOP. So finally, when you start the treatment, you have to keep in mind the patient characteristics and the drug properties. And once you select a drug, you follow up the patient and find if the target IOP is being achieved. If not, you can probably add a new drug or substitute and make sure that the target IOP is reached. All my slides are from guidelines from the European Glaucoma Society as well as the Glaucoma Society of India. Thank you once again for your patient listening.
Thank you, Abhilash sir. For the next talk, I invite Dr. Priyanka Shah to give a talk on update on rokinase inhibitor, the newest addition in our armamentarium.
Good morning, everyone. I'm Dr. Priyanka, and I'm going to talk on update on Rho kinase inhibitors, the newest addition in our armamentarium. As you all know, glaucomas are a group of progressive optic neuropathies characterized by optic disc excavation and apoptotic loss of retinal ganglion cells. IOP is a continuous risk factor for the development and progression of the disease, and the only effective therapeutic intervention which helps in slowing the disease progression is IOP reduction. So there are two outflow pathways for aqueous humor. 85% is through the trabecular outflow and 15% is through the uveoscleral outflow. There are three mechanisms by which IOP can be reduced. The first one is by decreasing the rate of aqueous humor formation. Second one is by increasing the aqueous outflow through the unconventional pathway. And the third one is by decreasing aqueous outflow resistance of the conventional outflow pathway. So anti-glaucoma medications have evolved from 1877, starting with the cholinergic agonists and finally ending with the Rho kinase inhibitors till date. But none of the medications currently available to reduce IOP address the underlying cause of elevated IOP that is commonly associated with glaucoma, namely increased outflow resistance. So this led to the search for an ideal anti-glaucoma medication which can lower the outflow resistance, which is highly effective during both diurnal and nocturnal periods, which is easy to use, that is once daily dosage, well tolerated with minimal adverse effects, which has a neuroprotective activity as well as which can improve the ocular perfusion. So this led to studies by Dr. Benjamin Geiger and Dr. Paul Kaufman, who showed that cytoskeletally active agents such as latrenkilin and H7 significantly decreased aqueous humor outflow resistance. These studies began a focus on the role of cell mechanics in the aqueous humor outflow pathways and the role of Rho kinase in this process. So what are Rho and Rho kinases? They are basically, Rho is a group of small GTP binding proteins which aid in the regulation of cell structure, motility, division and apoptosis. Rho kinases are effectors of the Rho pathways. There are two identified types of Rho kinases referred to as Rho kinase 1 and 2. They aid in the reorganization of actin cytoskeleton which help in cell growth, movement and death. Rho kinases are ubiquitous and expressed in all tissue types. They are mainly serine tyrosine kinases. So this picture shows the structure of a Rho kinase. In the left picture, you can see the intramolecular interactions of the autoinhibitory loop, which maintain the molecule in an inactive stage. In the right side, you can see when GTP binds to Rho, it becomes active. And this active form of Rho binds to the Rho binding domain of the Rho kinase, thereby activating the enzyme. So once active, the Rho kinase phosphorylates myosin light chain, myosin phosphatase substrates, limb kinase, CP117, calponin, and the ERM proteins. These factors serve a number of cellular roles, including cell adhesion, actomyosin contraction, cell migration, and cell proliferation. Through the depolymerization of intermediate filaments and modulation of microtubule dynamics and polarity, Rho kinase acts to increase the contractile state and stiffness of cells, which play a critical role in the outflow of aqueous humor. So Rho kinase inhibitors increase the blood flow by causing vascular smooth muscle relaxation, leading to vasodilatation. This can cause a conjunctival hyperemia. They have an anti-tumor activity by inhibiting tumor cell invasion and metastasis, and they also prevent axonal degeneration and promote axon regeneration. Now, what are the indications of Rho kinase inhibitors in ophthalmology? There are 4 approved indications. First one is in cornea, which is Fuchs endothelial corneal dystrophy. In glaucoma, ocular hypertension and primary open-angle glaucoma, and also it has a very good action in diabetic retinopathy. What is the role of cytoskeleton in determining aqueous humor outflow resistance? The streamlines on which the aqueous humor passes through the juxtacanalicula tissue are forced to funnel or converge to enter the widely spaced pores in the inner wall endothelium of the Schlemm's canal. And this non-uniform flow significantly increases the outflow resistance. So Rho kinase inhibitors act by decreasing this Schlemm's canal cell stiffness and by increasing the number of pores, thereby decreasing the aqueous outflow resistance. The mechanism of Rho kinase inhibitors' ability to decrease IOP is through direct action on trabecular meshwork and Schlemm's canal. They also decrease reactive oxidative species damage to the trabecular meshwork, and they promote vasodilatation and improved retinal blood flow, especially to the optic nerve head. The commonly used Rho kinase inhibitors in ophthalmology, they act on both ROCK1 and ROCK2. Fasudil, Ripasudil, and Netarsudil. Ripasudil and Netarsudil are the 2 Rho kinase inhibitors currently approved for treatment in glaucoma. So coming to Ripasudil, it is a fluorinated analog of Fasudil but with more potent and selective Rho kinase inhibitory activity. It was approved in Japan for the treatment of glaucoma and ocular hypertension in September 2014. It's Ripasudil. And various clinical trials have established Ripasudil 0.4% BD as a clinically useful concentration and dosing frequency for the treatment of glaucoma and ocular hypertension. This solution, on an average, it can lower IOP by 2 to 4.4 millimeters of mercury 2 hours after instillation in patients with glaucoma or ocular hypertension, and they can continue to deliver statistically significant pressure reduction for at least 7 hours. Placebo-controlled randomized controlled clinical trials to evaluate the additive IOP lowering efficacy of Ripasudil with either timolol or latanoprose showed that treatment with Ripasudil resulted in a lower mean IOP in the timolol group, with the additive effect being 0.9 millimeters of mercury at trough and 1.6 millimeters of mercury at peak. In the latanoprose group, there was no significant difference compared to placebo. Ripasudil as adjunctive treatment in patients already on maximal medical therapy demonstrated IOP reductions ranging from 2.6 to 3.1 millimeters of mercury, or about 15 to 16% from the baseline. However, the side effects of Ripasudil include dose-dependent conjunctival hyperemia and non-dose-dependent conjunctival hemorrhage. Coming to Netarsudil, which is also known as Ropressa, it's a Rho kinase inhibitor as well as a norepinephrine transporter inhibitor. It is approved for use in the US to treat glaucoma in the late 2017. It lowers IOP by 3 mechanisms: by lowering outflow resistance, decreasing aqueous humor production, and by decreasing episcleral venous pressure, which is mainly due to the norepinephrine transporter inhibitory activity. It is more effective in patients with lower baseline IOP, possibly due to its ability to lower episcleral venous pressure. So this is Ropressa or Netarsudil. Intraocular pressure lowering effect has been shown to increase with latanoprost. This fixed combination of Netarsudil and latanoprost is known as Roclatan. The side effects of Netarsudil include conjunctival hyperemia, corneal verticillata, instillation side pain, and conjunctival hemorrhages. So this is the fixed combination of Netarsudil and latanoprost, which is called as Roclatan. Now coming to the Rocket 1 and Rocket 2 studies, which are 2 phase 3 clinical trials comparing the safety and efficacy of Netarsudil to timolol in patients with elevated IOP, it has concluded that treatment with Netarsudil produced significantly and statistically significant reductions from baseline IOP and was non-inferior to timolol in patients with maximum baseline IOP of less than 25 millimeters of mercury in both studies. They also have a neuroprotection action on retinal ganglion cells. The Rho kinase inhibition results in enhanced axonal generation and increased blood flow. Thereby, they can slow the progression of glaucomatous optic neuropathy by by acting directly to increase the perfusion of retina and optic disc. Rho kinase inhibitors also have an effect on the conjunctival scarring after glaucoma surgery. Ripasudil acts by inhibiting the TGF-beta mediated increased expression of alpha smooth muscle actin. Thereby, intervention with a Rho kinase inhibitor could serve a dual purpose in post-trabeculectomy patients in that the drug could be used to lower IOP and to slow or prevent further scar formation. So to conclude, none of the Rho kinase inhibitors tested in various clinical trials proved themselves superior to commonly used first-line agents. However, they can be used as adjunctive agents since their mechanism of action is thought primarily to be one of lowering of aqueous humor outflow resistance and thus should be somewhat additive to the actions of other agents in clinical use. No known prior contraindications to the use of either Ripasudil or Netarsudil are found out, nor are there any known interactions with other medications. Thank you.
Thank you, Dr. Priyanka. For the next talk on lasers used in glaucoma management, Dr. Meenakshi is unfortunately unavailable. Dr. Rizana has graciously agreed to cover the topic for us. Over to you, Rizana.
Good morning. Today, I'll be presenting on lasers and glaucoma management. So, as we all know, lasers have simplified the management of glaucoma to a great extent. So, I'll be dealing with the lasers one by one in the order of frequency which it is used in the subspecialty of glaucoma. So, coming to laser peripheral iridotomy, which is the most commonly done laser procedure in glaucoma. It's a photodisruptive ND-YAG laser which is used in this for the treatment of pupillary block, and the indications include primary angle closure glaucoma, primary angle closure, some special situations in PSCS, and secondary angle closure glaucoma with pupillary block. So indications of PI in angle closure suspects. Patients who need frequent dilatations like diabetic patients, patients who are on anticholinergic drugs, type A personality and anxiety-related issues, those are unable to undergo regular follow-up, and prophylactically in the other eye of PACG or PAC. While planning for YAC-PI, you have to take an informed consent and explain that this is not for IOP control and explain the possible adverse effects that can happen, and tell them that multiple sittings might be required in rare cases, and they might be have to continue anti-glaucoma medications if IOP is not stabilized, and ask for history of use of anticoagulants. If yes, you may have to delay the procedure for 1 or 2 weeks and prepare the eye with pilocarpine 2% before the procedure. An Abram lens is used to get a clear view of iridotomy site, to get a greater focus of laser and to reduce collateral damage and to stabilize the eye and control bleeding and help to wash out pigments from the PI site to facilitate enlargement of the PI. And position, the initial teachings was to do it in the superior aspect in a portion well covered by the lid, but this notion does not hold true anymore, because the recent studies have shown that any position is okay, and preferably avoid supratemporal and supranasal area where the upper lid bifurcates. And you have to go for a thin area of the iris or for a good crypt. If it is in the inferior aspect, that is also fine, and avoid extreme peripheral crypts to avoid closure by the peripheral iris rolls after the effect of pilocarpine weans out. And avoid 3 o'clock and 9 o'clock position due to the presence of blood vessels and nerves there. Complications are intraocular pain, hyphema, dysphotopsia, and iritis, and if not done carefully, it can cause focal or generalized cataract, focal zonullar damage, DM detachment, endothelial cell loss, etc. Nolan et al. Found that laser PI leads to an increase in angle width by 2 Schaffer's grade. And another study conducted by Hay et al. Found that mean IOPs decreased by only 0.2 millimeters of mercury for every 10-degree difference in angle width after iridotomy in primary angle closure suspect eyes. So it is not of much help in reducing the IOP. Coming to the next application of laser in glaucoma, that is trabeculoplasties. It includes argon laser, selective laser, and micropulse diode laser trabeculoplasty. This is an effective, non-invasive, and easy to perform technique to reduce the intraocular pressure, especially for those who are not compliant about anti-glaucoma medications. And this can be done when medical therapy is inadequate, as an adjunct to medical therapy, or as a primary treatment modality. Indications are primary open-angle glaucoma, ocular hypertension, pregnant women, for those who are unable to undergo trabeculectomy, pseudoexfoliation, pigmentary glaucoma, and PAC status post PI. Contraindication, because this is a gonioscopy-aided procedure, if there is an adequate visualization of angle structures, this is not possible. Also in contraindicated in glaucoma associated with uveitis, trauma, and angle dysgenesis. So this is a table showing comparison of ALT with SLT. In ALT, 488 to 514 nanometer argon blue or green laser is used, whereas in SLT, frequency doubled Nd:YAG of 532 nanometer is used. In ALT, we target anterior portion of trabecular meshwork, whereas in SLT, the laser targets pigmented portion within the irradiation zone. That is a pigmented trabecular meshwork. In ALT, the mechanism is to cause shrinkage of the treated areas and opening up of the untreated areas. Whereas in SLT, the initial laser injury triggers a cellular response and tissue remodeling, which facilitates greater outflow. And in ALT, post-procedure inflammation is very high, and we may have to deal with it with dexamethasone or prednisone and acetate eye drops. Whereas in SLT, milder steroids or NSAIDs would be sufficient. And the complications in ALT, we can expect high IOP spikes and pars formation, which is not present in SLT. And retreatment in ALT is not possible because of high thermal damage induced in the first procedure, whereas SLT can be repeated, and SLT can be done in post-ALT eyes also. Future trabeculectomies carry a high risk high chance of failure in ALT patients, whereas SLT, this is fine. This is a picture showing the spot size, comparison of spot size of SLT versus ALT. The spot size of SLT is more, but the laser targets only the pigmented portion of the trabecular meshwork, whereas in ALT, the spot size is less and the power is more, and there is more collateral damage compared to SLT. ALT has been shown to reduce IOP and slow visual field progression in several multi-center randomized controlled trials, notably the early manifest glaucoma trial and advanced glaucoma intervention study. Also, the glaucoma laser trial also indicated that eyes initially treated with ALT have lower IOP and better visual field and optic disc status than the fellow eyes treated medically. So why we went for SLT? This table shows that IOP decreasing effect of ALT and SLT is almost comparable, but owing to the benefits which SLT has compared to ALT, that is less tissue damage, less evidence of pus formation, and more chance of trabeculectomy success in the future. Nowadays, SLT is performed and ALT is no longer done these days. And coming to the third modality, that is micropulse laser trabeculoplasty, indications are similar to ALT and SLT, and it has the advantage of having no visible thermal burns to angle structures, and it requires greater skill of surgeon because there is no visible mark created during the procedure. Micropulse is basically chopping a continuous wave into a beam of envelope of repeated short pulses. This is a picture showing comparison of the tissue damage produced by continuous wave versus micropulse. The second picture is a micropulse, and there is no evident damage to the trabecular meshwork after this procedure. So this is a study conducted by Sun et al. They compared micropulse laser trabeculectomy versus SLT. Success rates are comparable, and micropulse is to be considered in eyes in which IOP spikes cannot be tolerated. Coming to the next application of laser in glaucoma, that is laser cyclophotocoagulation. This includes transcleral, endoscopic, and micropulse diode. Basically, reduce aqueous production by destroying the ciliary body. Indication is for end-stage refractory glaucoma. Advantage is hypotony, vision loss, corneal edema. In transcleral, the probe is placed at the limbus and 18 nanometer diode laser is used. It can be done 180, 270 or 360 degrees, and 3 o'clock and 9 o'clock positions are avoided. The disadvantage is extensive architectural disruption of ciliary body, which may extend to pars plana and iris stroma. This is a picture post-procedure. In endoscopic, there is clear direct visualization of the ciliary body during the procedure, and it targets non-pigmented epithelium only, and there is no coagulated damage to tissues beyond the ciliary process. It can be done in as a limbal approach or pars plana approach. Advantage is less incidence of hypotony, phthisis, and severe vision loss compared to transcleral. Micropulse is again a transcleral approach, but there is less chance of collateral damage. It can be even used in seeing eyes, and there's less risk of hypotony. Next application is laser suture lysis, cutting the scleral flap nylon sutures post trabeculectomy. This will, the complications are in conjunctival perforation, flat AC, blood leak, prolonged hypotony, etc. Laser peripheral hydroplasty is used to widen the anterior chamber and break peripheral anterior synechiae in angle closure glaucoma, which are unresponsive to anti-glaucoma medications, in which there is significant corneal edema or shallow AC. Contraindications, non-visibility of iris due to corneal edema or opacity or flat AC. Endothelial burns, iris atrophy, and Urach-Zavaleta syndrome are reported after this. Other less commonly done laser techniques are Nd:YAG laser hyoidotomy in malignant glaucoma. Overhanging or avascular blebs can be treated with photocoagulative laser to produce superficial scarring of conjunctiva, and iridolendicular synecholysis can be done to break posterior synechia, which causes iris bombing. Thank you so much.
A very good morning. A very good morning, everyone. I'll be talking to you on trabeculectomy, optimizing outcomes and improving safety. There is a war going on between Microsoft and Apple, so we can expect some problems with the videos. Acknowledgement to Dr. Pengtiko from Moorfields Eye Hospital, London, for producing the Moorfield Safe Surgery System. My talk will not be on safe surgery system, but how to incorporate those principles into our surgical practice. This is what we all want: a moderately elevated diffuse bleb with matching color of the surrounding conjunctiva with low tine pressures. In our quest for that, we may end up with an overfiltration with higher risk of hypotony and decreased visual acuity with hypotonic maculopathy, and over time, the bleb scarring and leading to low success rate. If you err towards safety, then we may end up with a higher IOP and lower success rate. So the purpose of this talk is to how to incorporate safe surgery system practices to improve consistency and outcome. First position of the filtering bulb is positioned underneath the upper eyelid. If upper conjunctiva is scarred, then we can opt for a glaucoma drainage device instead. So clear corneal traction sutures are preferred over the superior rectus brittle suture because it avoids conjunctival tears or subconjunctival hemorrhage. A fornix-based flap is preferred or limbal-based flap because it gives good scleral exposure, good control of the surgical site, eliminates posterior restricting scar. Try to avoid radial side relaxing incisions. If it is must, use it on one side so it gives better visualization of the sclera but doesn't compromise on the perfusion area. Dissect backwards with Westcott scissors to make a pocket approximately 10 millimeters on either side of the superior rectus insertion. This is the earlier ring of steel formation and the problem with the limbal based incisions, which are not seen nowadays. Next, coming to scleral bed cautery. The C-shaped wet field cautery is done posterior to the desired scleral flap area. This avoids scleral tissue scarring or charring. This reduces the risk of scleral flap fibrosis. Also, there is no risk of bleed because these blood vessels, even though they are near the scleral flap area, they don't bleed when you dissect because they are not in communication with the posterior blood vessels. Next, antimetabolic use. Sponges soaked with mitomycin C, 0.4 mg per ml, is placed posteriorly into the conjunctival space, subconjunctival space. I prefer to use it prior to the scleral flap dissection because it reduces the risk of MMC entering the anterior chamber and complications related to that. Enlarging the surface area of treatment area results in more diffuse, non-cystic bleb, posterior bleb. It also prevents the ring of steel formation. Alternatively, we can give subconjunctival injection of 0.1 ml of 0.1 mg per ml MMC injection given 10 mm behind the limbus prior to conjunctival incision. Next, coming to scleral flap dissection, we can choose either rectangular or triangular flap. I prefer triangular flap, a 4 mm base. The key is to avoid cutting the side walls right up to the limbus. The central area is dissected into the cornea, but the side walls stop short of the limbus. This encourages posterior flow of aqueous and reduces the incidence of cystic blebs and overhanging blebs. Before entering the main port, we need to make a paracentesis side port. This gives fine control of the anterior chamber. Oblique paracentesis minimizes the risk of lens touch and lens damage, especially if an anterior chamber maintenance needs to be used. Use pilocarpine prior to injection of hydroxypropyl methylcellulose if that is what we are choosing to use. The constructed pupil gives us a better surgical iridectomy later. It is imperative that we prevent intraoperative hypertony to reduce complications like choroidal hemorrhage or aqueous misdirection. Coming to sclerostomy, anterior chamber entry is done slightly anterior to the gray-white junction. More anterior increases safety. This incision wound should be slightly larger than the punch head. Kelly sponge is aligned perpendicular to the eye to ensure a clean, non-shoved sclerostomy. Smaller sclerostomies are also okay, but the important thing is that ostium should not be eccentric. It should be central, and on either side of the ostium there should be 1 to 1.5 mm of scleral cover. Next is iridectomy. A broad-based surgical iridectomy is what we are aiming for. If the iris tissue gets incarcerated, and when you see a peaking of the pupil superiorly, that means there is iris incarcerated in the ostium. This needs to be taken care by injecting visco through the ostium. Next is suturing the scleral flap. Apical suture is used first. This should be an appositional suture and not a compression suture. If this happens to be a tension suture, then the side releasable sutures will not work. So this has to be just an appositional suture. The side walls are closed with compression sutures. I use releasable sutures. So this allows us to give tighter sutures, which reduces the risk of hypotony or overfiltering blood immediate postoperatively. If we want to increase the filtration, we can always choose to release these releasable sutures postoperatively. They are effective from the first 4 to 6 weeks. For putting the releasable sutures, a corneal loop is made, and 4 throws are taken and optimally tightened without locking. Before closing the conjunctiva, make sure that we wash the viscoelastic completely from the anterior chamber and hydrate the side ports. The anterior chamber should be not collapsed, it should be well formed at the end of surgery. Use a dry Vexel sponge to dry the scleral flap area and look for the egress of aqueous. If there is too much of wetting, then we have to tighten the sutures. If we need to make it loose, we can just gently rock the sutures, the releasable sutures sideways to ease the tension on the releasable sutures. Next, one of the most important steps is closure of the conjunctiva. We need a watertight closure of the conjunctiva. What we aim for is a good limbal tension line. We can use Vicryl or nylon. Recently, I've started using nylon to improve the safety. So now we can see the good tension on the limbus superiorly. This can be additionally be reinforced by using a nylon horizontal trapezoidal suture. This technique has more or less completely eliminated central conjunctival retraction or limbal leaks. At the end of the surgery, we can give subpunctal injection of cycloplegic mydriatics, antibiotics inferiorly, and once we inject BSS into the anterior chamber, we can see the blood forming. So, by changing alterations made in the construction of the conjunctival and scleral flaps, and with the introduction of releasable sutures, which allows tighter closure, with the option of releasing them postoperatively, we can optimize the outcomes and improve safety. Thank you.
Wonderful talk, Manoj. Great videos.
We have time for discussion. If there are any questions from the audience, we can take. Ma'am, we will be removing them at the end of 6 weeks. We don't keep it there, so it doesn't matter. The ostium can induce astigmatism, so it is preferable to keep the ostium smaller to reduce astigmatism. A larger, broader ostiums can induce more astigmatism. Sorry, corneal traction sutures will not cause astigmatism because we will be releasing it. All right, all right. Dr. Priyanka, which rho kinase inhibitor do you prefer over between netasodil and repasodil?
I prefer Netarsudil because it is once daily dosage, like night time, and patients will be more compliant to it. But the only side effect is conjunctival hyperemia. However, if we maintain the cold chain, we ask the patients to keep that in the refrigerator so as to maintain the cold chain. What the pharma company says, it can be refrigerated until the patient opens it. Like from the pharmacy till when you reach home, you have to keep it in the refrigerator, and once you open, you can keep it outside. That's what the pharma company say. But if we ask the patient to keep it in the refrigerator, even after opening the drops, the incidence of conjunctival hyperemia will be less. That's what I have seen.
So do you use it as an additional second drug, third drug, or fourth drug?
Maybe second drug I can use, like after, along with latanoprost, because the latanoprost is also once daily dosage. And along with that, as a second drop, I usually advise for rho kinase inhibitors.
I have had two experiences where after introducing the ROCK inhibitors, the patient became intolerable to medical management. They suddenly have red eyes and itching, and after stopping this ROCK, still the patient continues to have these complaints, and even after stopping all the medicines, they will become better. But introducing the earlier tolerated agents becomes also difficult. So I've had two cases like that. Whether you've had any experience like that?
Yeah, we have to inform the patient well in advance that you will have conjunctival hyperemia, your eyes will look red, but it's like self-resolving. For many patients, it will resolve within maybe 48 hours of usage, but some people will be very like they want to know why this redness has happened. So for such patients, you can stop them, and after stopping, these conjunctival hyperemia usually resolves. First line, usually we prefer prostaglandin analogs. Timolol, nowadays we don't prefer as a first line drug.
It's still, ma'am, it's still very good drug. We still use it as first line. So it is either between timolol or PG analog, because timolol will give you 28 to 30% reduction in IOP, and if it is well tolerated by the patient, we can give timolol. There's no problem. Absolutely, we should definitely consider that aspect when we prescribe medicines. Dr. Rizana was saying that socioeconomic status of the patient needs to be considered before prescribing medicines. So timolol is still number one drug. Absolutely. Yes, ma'am. Correct. Well, PG analogs definitely is better than timolol. Timolol is twice daily administration that reduces the compliance. PG analog is single time administration which improves the compliance. The amount of IOP reduction is better with PG analog, and there is no risk. There is no risk of inducing asthma or anything like that. So currently, PG analogs are preferred if the patient can afford it. If not, yes, timolol can be given.
Ma'am, please tell me the comparison of cost of rho kinase inhibitors with prostaglandin analogs.
Cost is almost same. Like but since this is a branded company, like the cost will be slightly higher than the like prostaglandin analogs.
Currently, PG analogs are available at all cost. Now, Indian farmers have brought in PG analogs, so it's the price have come down dramatically. So,
Reiki and all will cost around?
475, that range. And I think Sun Pharma is coming up with this Rocklatan type of combination. They told it like it will be released in another 3 or 4 months, like latanoprost with netarsudil. So that will be more convenient for the patient. You can give it as a one drop night dosage.
No, I think regarding PG analogs, as Manoj said, you can get it from around 250 rupees to 700, 800 rupees. Especially if you want preservative-free medicines, too many medicines on the eye, preservatives probably are not a good idea. So, if you want preservative-free, they will go towards more expensive range. As far as rho kinase inhibitors are considered, I think the once daily netarsudil is on the expensive side and the ripasudil is on the lower cost side, but you have to use it twice a day. Rho kinase or the PG analogs? Latanoprost. See, if you are using generic medicines, well, you will have to see if it is good enough or not. Yes. Madam, that you'll have to check by, I mean, by clinically you'll have to check whether the medicine is working or not for your patient. So if with a particular generic medicine, if you are not achieving the target. Yeah, that is the generic version. Generic version. Yes, so if you are not getting the, supposing you are starting latanoprost, you expect at least 25 to 30% reduction. That is what latanoprost should ideally give you. But the medicine that the patient is buying, and you are getting only a 10-15% reduction, that means that medicine is not working. Whether it is low cost or high cost, if it is not working, it has to be changed. So even latanoprost is available from 250 to 60 rupees also. So that is also there. But the more expensive brands will be more than 500, 600 rupees. Yeah, there is no drug control. We can't we can't be sure that the medicine that you are giving is giving that much percentage of. Yes. So that you'll have to take it on a clinical basis whether you are getting a reduction or not. There are lots of low cost medicines available now. Brands are there. Netasodil is available. There are quite a few. Netalo, Reiki.
Reiki, Raiki, Reiki.
Netalo,
Netalo.
Netalo is there. Around 500.
There's a scheme. They get three. They buy three. They get one free.
3 plus 1 free is.
Are there any more questions from the audience? Else we'll wind up the session. Thank you all.